So as I've thought about the topic, I shall review with you some of the overlooked things that I often apply in my clinical practice, and I will be grouping these as maldigestion, bile acid binding, and preprandial loperamide. You heard some of these from the previous speakers as well. And then we'll address some other aspects on the use of 5-HT3 antagonists, fecal incontinence, and the use of pyridostigmine. I will comment on what I'm seeing a lot in clinical practice, which is the long-term use of rifaximin, which I don't think is indicated by the FDA approval, and then emerging drugs, a ghrelin receptor agonist, a new 5-HT4 agonist, a new drug class called NHE3 inhibitors, the sodium hydrogen exchanger inhibitors, bile acid modulation, and then a really promising a new approach to visceral pain targeting histamine H1 receptors. So let's start off with that first group of topics together. Now, this is the slide that Dr. Crow just showed us, and that is the fact that a diet low in FODMAPs reduces symptoms of IBS as well as traditional dietary advice. I like, when I teach about this, I like to put this title the other way around, and that is traditional dietary advice is as good as FODMAP, low FODMAP diet. And I think it's important to go through the details of what the NICE Excellence project in the United Kingdom and the British Dietetic Association recommended in these dietetic advice. Regularly eat 3 meals and 3 snacks a day. Never eat too much or too little each time. Never be hungry or too full. Eat in peace and quiet. Chew thoroughly. Reduce the intake of fatty or spicy foods, coffee, alcohol, onions, cabbage, beans. Avoid soft drinks, carbonated beverages. Eat fibers, but distribute them, the intake of the fiber, evenly throughout the day. And Dr. Crow had shown us earlier that the randomized controlled trial showed absolutely no difference between traditional dietetic advice and the low FODMAP diet.